Well, welcome everybody to our second annual lecture in shoulder surgery. We are really privileged to have Dr. Flatow here. You can see Dr. Flatow earlier in his career up in the lab where we spend a lot of our time. Evan was born and raised in New York City. He got his AB in biochemistry at Princeton. He was a Columbia P&S medical student. He can tell you war stories about being a resident here from 1981 to 1986. And he was Dr. Neer's shoulder fellow, and he was sharing some of those stories last night at dinner.
St. Patrick's Day parade.
Yeah.
That's my son Sean.
And how old is Sean today?
33. But when we went to the Oak Room, I had two sons, David and Sean, and David was sitting around looking at Dr. Neer saw Sean flirting with the waitresses and David staring, and he said, David's going to be a scientist and Sean's going to be a bartender.
No, Sean's an ADA.
He was an ADA, but he was the social chair of the craft college. David is a computer science mathematician.
Evan joined the faculty here at NYOH in Columbia in 1987, and he was here till 1998. I arrived in August of 1998, and Evan left in October of 1998, and I had nothing to do with his departure, I promise. He is the Bernard Lasker Professor of Orthopedic Surgery at Mount Sinai. He left to be the chief of the shoulder service, and then in 2006 became the chair of the Department of Orthopedic Surgery. And then in 2014 took a completely different career path and became the president of Mount Sinai West, and still maintains his clinical practice as a shoulder surgeon as well. Dr. Flatow's career has been marked by incredible awards and success. We just had our graduation this past weekend, Evan, and Evan was the recipient of the Frank Stinchfield Award twice. He was an ASCS traveling fellow. He was a ABC AOA traveling fellow in 1995. He went on lots of traveling fellowships. He's the past president of the ASCS, and he's had significant leadership roles at the Academy as the chair of the Publications Committee, and then the chair of the Council of Education from 14 to 18, where he really influenced a lot of changes in the positive direction for under his leadership. His scholarly productivity is incredible: 161 peer-reviewed papers, 80 book chapters, 18 textbook or journal editors, and over 250 presentations domestically and internationally. And he's going to talk today a lot about perils and pitfalls with industry, but he and Louis designed the prosthesis that for 7 years running was the #1 sold shoulder prosthesis in the world. And so we'll hear a lot about that, but it really did change the way that we think about shoulder arthroplasty. So this is the second annual WNL lectureship, and Louis gave the first lecture in 2019, and we had to cancel last year's because of the pandemic. And it goes without saying that I talk a lot about mentorship, as you guys know, and these two were the mentors that paved the pathway for me to be here today. And I am forever indebted to both, and specifically to Evan, for all of the opportunities that he has provided me in my professional career. So the 2021 WNL lecture, which is very generously donated by Mary and Dan Rue, is Dr. Evan Flatow.
Well, it's a great, honor to be here. One time we had an alumni meeting, Mel was at, I was at, where the projector wasn't working, and Hal Dick yelled to Leon Costa, "Go fix that!" And he jumped up and fixed it. And then he came back and sat down next to me and he said, "Once a boy, always a boy." And when you go home, you start to take on the memories of what you were here. But I really grew up here, and I had the privilege of not only being, a medical student here, a resident, and then on the faculty here. So I really, had the full experience. And I left not because I wasn't happy, but because at a certain point, you sort of want to fly in your own wings. And Mount Sinai didn't have any shoulder surgeons, really, just had a few people doing it. And the chance to sort of start my own, I had lunch with Russ Warren. We were talking about this, and he said sometimes it's nice to go some new place and build something new. And It's not that Louis wouldn't let me change things. I just wouldn't think of changing something without talking to him, because he was my mentor and my chief. And so you want to go to a place where you can make your own mistakes. So it was fun, but my career took some wild turns. Charlie Neer once said to me, talking about careers, he said, "Who's the president of this hospital?" I said, "Tom Morris." He said, "Who's the last president?" I go, "I don't know." He said, "How important a job can that be?" He asked me who invented hip replacement. I said, "Sir John Charnley." He said, "So you know the name of a consultant orthopedist in rural England 50 years ago, and you don't know the name of the last president of your hospital? Let that be a lesson to you. Don't ever be a committee man." That's what he called it. So he would be ashamed of me today. And I did not pick this path. My boss said, "I need you to do this." And I'm old school. I need you to do something, you do it. But it's been a fun ride. And we can, on another day, we can talk about what it's like to become an administrator responsible for a budget and all of that. But today, I thought I'd talk about, and I've never actually given this talk, and it was a lot of fun, Bill, putting it together. I've talked about the joy of innovation, the excitement of new things, but I never talk about the perils of it. And I've lived that. I mean, I know that pretty clearly. So I thought it was good, especially for you young people who are going to revolutionize medicine someday, and we're all looking forward to that, to talk about the guardrails that you have to think about when you deal with industry. So I do have a disclosure. I make money from patents and relationships with Zimmer, and then a tiny bit with Inamed because of instruments. I always say I don't make much myself. My family seems to get it all, but I do have that conflict of interest. I have wonderful memories of being here. And of course, Bill, I first met when he was an undergraduate at Stanford, 19 years old. He was the junior. He was the younger brother of one of my wife's closest friends, and they're still friends 30 years later, the group of girls who go on trips together and dinners and were students together. So I never dreamed he would be my fellow someday, my colleague, a chair, but we met him at a very early stage in his career. Mentorship, as you mentioned, is very important. This is actually a picture by Tiepolo of Mentor, who was the tutor that Odysseus entrusted his son Telemachus to when he went off on his journeys. And that's really where the name comes from. So Mark Kirshner was my mentor at college, who was my thesis advisor in biochemistry, went on to be chair of molecular biology at Harvard, and an amazing guy. Obviously, my clinical mentors, Dr. Neer and Dr. Biliani, were the major forces in my clinical career. And then Van Mao was my scientific mentor in orthopedic science. So people ask me how to have a good career in academics. I say the key is to be lucky. And you have to be lucky. And it's very hard, because to have remarkable people willing to spend time with you to help foster your career is a very special thing. And what's amazing about places like Columbia is to have such a concentration of those people, because you can go to many places and get no one who could serve as a mentor or one person, but to have had this group of people was an amazing thing for me. They were also role models. Dr. Neer and Louis both took August off in the summer. I'm not sure I would have. My parents always spent August in the country, but I'm a sort of workaholic, and I'm not sure I would have done it. But they sort of inspired that, and it's been the lifeblood of my life. It's really saved me that time to recharge. They taught me always to do the right thing, always to restrain yourself a little bit, not to go for that last dollar or that last thing, but always to think of things. But on the other hand, and I always remember Dr. Neer telling me, he said, "Don't be a fool." He gave me the story of Clay Ray Murray here at the fracture service, who devoted everything to the hospital, was on salary, and turned over all his patients to be fundraisers. And then when he died young, his family was left penniless, and they wouldn't even admit him to the hospital. The attendings had to take up a collection, which really singed Dr. Neer at a young age. So he always said, be generous, be good, but don't be a fool. Protect yourself, protect your family. And I'll get back to that, but be thoughtful in your choices. The other thing he said is that a doctor should drive a nice car, but not too nice a car. You should, you don't want to be thinking about your mortgage payment when you're debating if Mrs. Jones needs her cuff repaired. You always want to have some perspective. And that's important to this talk, because we're talking about the risks of financial involvement in non-medical things. So I'd like to start with what I call the hierarchy of industry involvement, which is when you look at these things, there is true, original, game-changing intellectual property. You come up with an idea, the idea sells itself. You almost don't need to do anything to promote it or push it. Examples are cannulated screws. The shaver, Lanny Johnson patented the shaver. Cannulated screws is that guy in Alaska, I can't remember his name, who patented that. Patient-specific instruments that Joe Ionati developed. These are really innovations and they're usually patented. These are the most illegally and ethically protected category, and I'll get back into that later. Everyone accepts, it's like in computer science and anything else, that you're advancing innovation and you're helping patients. True original incremental improvement is like one tier down from that. That's, new implant system, can be consulting or royalties, make it bigger, make it smaller, make it fit in my hand, make the approach easier, new instruments. Then the third down is day-to-day improvement, and this is usually consulting. It's just, how to keep on the right edge, how to keep companies knowing what's going on. And then there's validation, and this is where it starts to get a little gray. Surgeon education, clinical research, try new products. It's okay to a point, but you have to be careful about endorsement. It's the old Michael Jordan pumping up his sneakers before a game so everyone will buy Air Jordans. It's really not okay to endorse products. And that's often what companies are coming to you for. They want to tell people that Mark Weidenbaum uses this implant system, or Mike Vitale likes this kind of device. And you can't help it a little bit because it feeds our egos, but it's not appropriate. It's certainly not appropriate to sell it. Whether you want to do it because you believe in something, it's different than selling it. And then there's marketing, which is never okay. It's never okay to market a product, especially for an academician, or a leader. But, a company will see all of these facets in you. They'll see all of these aspects. Now, the Bayh-Dole Act of 1980, until that act, all discoveries from NIH-funded and other government-funded research belonged to the federal government. And they did very little with it. In fact, I don't think a single drug was made from discoveries during that whole time. What they did was to vest the patents and the IP in the institutions that sponsored them. The institutions typically share them with the inventors. I think Columbia may still be, used to be 33% went to the inventor and the rest went to the school or the institution. This led to one of the biggest expansions of biomedical research in history. It became the envy of the world, all the discoveries, all the drugs. But some people criticize this today. They point to a drug company and say they're making money off a patent that was from, it was all done by NIH research. It's a little bit like the spin-off from aerospace industry and other kinds of things where it used to be considered a good thing to put innovation and IP into the economy to let the industry do well, but there are debates about it now. And the vaccines is an example. Like, why are these companies benefiting? Why can't poor countries buy it? So I don't want to say it's a settled issue, but this was considered at the time and still is, I think, by most people, one of the major changes in it. But the point I'm making is it is U.S. government policy by both parties, by all parties, that innovation should benefit financially. This is not like something that was done sneakily on the side. This is government policy, and it's officially recognized. But what are the problems and risks with industry involvement? There's conflicts in research and publications, bias in results that can taint what you're publishing. There are conflicts in motives for human subject research and a potential for injury. If you're financially conflicted and want to show something is great, you may be inappropriately enrolling patients in studies, you may be doing inappropriate care for them, and that can drive some bad things. There are kickback issues with companies. Are companies paying you for your IP, or are they paying you for endorsements or for marketing? And then there's fraud and conflict about hospital purchasing. If Bill has a committee on what we're going to buy, which anchors, he wants to know, are you on the payroll of a company when you're asking this hospital to spend their tax-deductible, tax-exempt dollars on those implants, and you're getting a kickback, which is what it amounts to. So these are all complex issues. The U.S. Department of Justice had the deferred prosecution agreement in 2007 when many of you were in high school, when they sued Zimmer Biomet, DePuy, Smith & Nephew with a deferred prosecution agreement. This is a pretty big deal for a company. If you're indicted, you lose all ability to go to the credit markets. It's like what happened to the big accounting firm, Arthur Andersen. You wind up basically bankrupt overnight, and the government doesn't even have to prove its case. The minute they indict you, you're out. So that's a big stick to use. And they made the companies, they accused them of violating the federal anti-kickback provision because they said surgeons were paid to use implants, not real IP. There were examples of hip surgeons who did 500 company A hips. December 31st, their consulting contracts ends. Company B's contract starts January 1st, and they start doing 500 of Company B, right? And this pattern, went on a great deal. And they'd meet a couple of times a year and have dinner and drink some wine and give the company some kind of non-specific feedback. They paid over $300 million in fines. By the way, more than half of it from Zimmer alone, by the way. They had to have federal monitors for many years. The consultants had to disclose to patients. And this actually was one of the things that started the whole public list of people being funded, because the companies were required to publish the list of payments to doctors. The consultants have to disclose to patients. And they started a needs assessment for consulting, a cap on fees. No more than $500 an hour without special reasons. Royalties are generally capped at 4% for the group of designers. So you may wonder what pure and chaste people devoted their career to exposing this horrible mess. What wonderful human beings with a penchant for the public interest were behind this deferred execution agreement. Who were the heroes who fought for justice? Mike, do you know who they were? Must be great. Indeed. It was Chris Christie, soon to run for governor, who appointed his old buddies to be the monitors for the companies. John Ashcroft got $50 million in fees alone from monitoring Zimmer. Zimmer reviewed my contract. Louis and my contract were the only contracts that were deemed perfect and allowed to stand. All the hip and knee ones got thrown out. And it was quite a time. They also said you couldn't make more than $500 an hour, except for the monitors. And in fact, many of the monitors wouldn't allow, ski courses, except one time, one of the monitors for Depew, Jerry Williams, told me this. She said, okay, I'll allow it. I have to come to see that you're not doing anything bad. So she had them get a condo for her whole family and pay her to be there. And then after she saw it, she said, I don't think you should do any more of these, but this was okay. So, life is a bit messy, and the money from this was used to fund his gubernatorial race. We steered clear of that, partly because Louis was a great student of New Jersey politics, had lunch with Chris Christie, knew exactly what was coming, and gave us very good advice about not getting into the middle of this. And that led to heightened scrutiny. For doctors on payrolls, there's studies that show that doctors on the payroll prescribe more drugs from the companies that paid them off. And many of you have seen Dollars for Docs. If you just Google it, you'll come up with you can look up all your buddies. It's a great engine of envy at most medical schools for people to check on what their buddies are doing. The companies have to post payments. The students react with extreme positions. There's a movement at many medical schools. You shouldn't even take a pen from a company. And the problem is drugs are a little different because you don't need a whole lot of IP to make a drug. You just need that original thing. And so there is debate over what you really need all these consultants for about a drug that's being marketed. Surgery is a little different because people have to learn how to use the implants. They have to learn the indications. They have to learn the tricks. And so it's a lot harder. It's like teaching someone to play the violin, not just making the violin, as opposed to just taking a pill. However, it's become a source of ethical debate. There are different perceptions of conflict of interest. I can tell you all the time, I have colleagues who say to me, don't you think your patients would be upset to know you benefit from some of these things? And then I explain to every patient my conflict. I've never had one who didn't say, of course I know that. I looked online. That's why I came here. I want to go to the guy who made the piece, right? But I can tell you, if an untoward outcome happens, if there's a lawsuit, their attorney is going to take the position that you were conflicted, and why did you do that? I should point out that no one gets royalties on implants they put in themselves. You only get them on places done outside of hospitals where you work because you're not allowed to get a kickback on something you do. But nevertheless, there is that issue. So what do? I have signs in the waiting room that talk about our faculty are innovators and they benefit from working with research. I tell every patient about my conflict. I write a note about telling the patient about my conflict. Every patient pre-op signs a statement that they understood my conflict and that I offered to refer them to another doctor that didn't have a conflict if they were interested. My website lists conflict. Here's our website. That's my page on the website. And right there at the bottom is consulting, Zimmer Biomed, et cetera. So disclosure, however, is not enough. I'll get into that in a moment, but you certainly have to disclose. If you're going to do this, you have to disclose. So what are the strategies for conflict of interest in research? Historically, disclosure was all that was needed. You just had to show that you had a disclosure, and then everyone could think of that on their own. The second strategy is to manage the conflict by having an unconflicted PI, firewalls between data and interpretation, institutional committees that try to manage it. By the way, institutional conflict, which is a topic for another day, is not very well managed. So many medical schools have patents and drugs and things, and it isn't really very well managed how they manage that. It's individuals that's managed. And I can talk to you a little bit about that. We just launched a huge company, Semaphore, based on our genetics work. And it's an interesting thing how we have our own people use it, et cetera. And of course, you cannot do research. You can be pure. I read a very interesting book about Abraham Lincoln called The Ethical Development of Abraham Lincoln. And it made the point that you can be a hermit in the woods and not harm a fly and have a very ethical life and get nothing done. Or you can be a cruel dictator and do all kinds of amazing things by bad methods. But he said the amazing thing about Lincoln was that he waged war, passed a budget, founded a political party, and by and large never lost his ethical compass. That's the hard thing in life, right? So it's very easy to criticize. It's hard to figure out a path to productive development of things for our patients, of innovations, and not grapple with these issues. The AAMC published a series of, the American Association of Medical Colleges published a series of studies of this, and I've read them all. I would read them if you're interested in this. It's actually very, very eye-opening. You had one of your people from Columbia was on it. One of our head of our Gene Therapy Institute was on it. I mean, it's a good representation on the panel. And the major thing they came up with is the rebuttable presumption that a conflicted investigator should not do human subject research. You got to prove that it's good to do it. On the other hand, there was a footnote, a very small footnote that said, the inventor of an implantable medical device who under the Bayh-Dole Act might receive royalty income might also be compensated to train physicians to use the device and might be the individual is best qualified to implant the device in human subjects safely under experimental conditions. The point being that there's an ethical obligation of inventors to prove things are safe before anyone else will use them. So the very document that put out the rebuttable presumption points out that you also have an ethical obligation to be one of the early investigators. But what shouldn't you do? You probably shouldn't do 20 years of articles on why that's the best device. You should let other people who are unconflicted come out there and evaluate it. And we remember the Swanson implants, those silicone things. I mean, there are many examples, and it's not just financial, by the way. Another topic is, it's conflicts, intellectual conflicts, school of thought conflicts, defending acromioplasty against acromioplasty. There are many kinds of intellectual distortions that affect how we do things. The IRB, that'll save us, right? They'll figure everything out. They'll protect our patients. The IRB is an interesting thing. We can talk all day about that too, but you think they'll take a bullet for you? You were talking about the ENT surgeons, right? They don't benefit from the amazing surgery you do. They just don't want to be blamed when something happens, right? It's a distortion in the risk benefit. The cost benefit to them. You win the Nobel Prize in cure cancer. One patient complains to the New York Times that they were experimented on. That isn't even a hard choice. That isn't even a hard choice. They don't care about your Nobel Prize. They don't care about you curing cancer. They just don't want anyone harmed, and they don't want to be blamed that anyone's harmed. So that mechanism has not been as good as we thought it would be. And a conflict of interest just adds to the reticence, and it gives them an excuse to say no. So I'm being a little unfair because they're run by really good people, and we all know them. But the way it's set up as an adversarial system is not necessarily the best way to blend this all. There's also the problem of data sharing. Patents are hard to defend. Companies like trade secrets. Companies like good results. Now, in statistics, if you can prove it's less than 0.05, one way to get there is to just not publish the 19 studies that had a different result. So, even if you do a multivariate analysis, they don't know all the studies you didn't publish. So companies don't like to see bad results. So really one of the big no-nos in this is to let companies control your academic output. What we usually allow is a delay. We allow the company a little time to review the data, to give you some input on it, but not to block publication. And then, of course, the other facet is education. Now, companies cannot promote non-FDA approved devices. And the big example of that is the pedicle screw. As a licensed physician, you can go into a hardware store, take a screw off the shelf. And by the way, when I was an intern, and Mark remembers this, we used the wood screw. I thought that was Dr. Wood. No, that's a wood screw, as opposed to a metal screw. That's what we put in olecranons. And as a physician, unlike a advanced practice provider or chiropractor, et cetera, has an unlimited license. You can do anything you want. It's the hospital that, with their privileging, that holds you back from doing things, or your boards or things like that. But you can use them, but you can't talk about it. You have to be careful. You got to be careful teaching non-FDA approved uses. And this gets into a problem with industry where the academy got sued over this, over promoting pedicle screws at courses. An example is I designed, which I'll mention later, a ingrowth glenoid that could be used without cement, but it wasn't approved for use without cement. And people all over the world used it without cement, but I always put a little dab of cement on it because I didn't want to be the person doing a non-approved use of something I had designed, because I didn't want to be accused of stretching the rules. It was just something to think about. I think this is the big choice for an academician. I mean, obviously you can not do industry work, and that's great if you're in a field where you don't need industry. I don't need industry to do many things. I can get good anchors to do rotator cuffs. I can do studies of it, but I need industry to improve prostheses. I can't make my own prostheses. So everyone has to make that debate. If you align industry involvement with your research focus, there's tremendous synergy. Think of Mark Frankel and reverse prostheses, right? Tremendous synergy. You get funds for outcomes research and trials. You get early on trade courses backed by industry. You're suddenly on all the meetings talking about it because the hot topic is that new device. But you have a risk of being tainted very early. And your work can be so aligned with industry if you do it too early. Now, we all know examples of people who right out of fellowship are just jumping in bed with companies, and they never really get a chance to establish themselves by any independent peer review mechanism. I think it's ideal to start with industry involvement after you've established your reputation by some other mechanism, because otherwise you really risk going down a path from which there's no return. Where you don't have other opportunities, and also peer reviewers are going to be a little suspicious of you. The other thing you can do is have your industry involvement apart from your research focus. Then you have no conflict of interest in the area that you're interested in. There's no limit on publications or presentations, but I can tell you it's much, much harder to fund research or get any funds to do it. Now that's the path that I took. My story was I had a research career in tendon and cuff. I had an ORAF CDA, Bill mentioned, an NIH, KO8, and then with Dr. Vitale here, who in an earlier crazy moment was interested in shoulder before he got interested in little people. We did the first prospective ORAF grant on cuff outcomes and time trade-off, et cetera. We actually proved, incidentally, that rotator cuff repair is much more cost-effective than renal dialysis or heart surgery. I don't know why you have a heart hospital. You should have an orthopedic hospital here. Much, much more cost-effective, and we had the data to prove it. And then I started with my NIH R01 with the tendon pathobiology and a little bit on stem cells. My clinical research career was in fractures, arthroscopy, arthroplasty, as you know. My industry involvement was only in prostheses. I declined opportunities to be involved. MyTech came to Louis and I very early, wanted us to be involved with them. A lot of companies. I just wanted to keep cuff sort of pure so that I could do my outcomes work there. And that worked for me. I don't know that it works for everybody, but it's just a model I put out there that you can compartmentalize your career a little bit. As a result, I have not published a lot of papers on arthroplasty. We did in the beginning, but since I began to benefit from royalties, I sort of stopped writing arthroplasty articles. And just now, one of my partners, Paul Cagle, is looking up a lot of my practice. And it's sort of weird because I'm really doing nothing in the study. They use my patients, they come and look at my charts, they have a research person come, and it's sort of cool. It's like I'm waiting to see I want to see what happens. It's like a little bit of a drama. And then I mentioned my administrative derailment, which actually led me to give up my basic science career because The dean thought I could do everything. You know my dean. I thought that was crazy. I couldn't mentor students. I'd be abusing my postdocs, having them write my papers and my grants. So I didn't want to give up practice, so I gave up my basic science career, which was a bittersweet thing. But you have to know what your limitations are if you want to do a good job in anything. So we made the Biliani Flatow. I told you, some of you I'd mentioned this. We had a great name. We were going to be Legacy, and then the knee boys stole it. And the men and women of the knee replacement group at Zimmer, who make a lot more money for Zimmer than us, just grabbed. We had vetted this in 112 countries. The way this works is you got to be sure it doesn't mean, decaying donkey in some language somewhere. So you got to make sure it isn't the name of some kind of hygiene product. You have to really understand that it's a good name, and they do studies of it. So we had spent 2 years, we had the name Legacy, and then they decided to take it so we had like a week to file with the FDA, and they needed a name, and the only one they could figure out was to use our name. I don't recommend it. People come in with a draining, infected, this is your prosthesis. They put your prosthesis in here. What happened? People can Google it, and when they Google me, they get this. So I don't recommend it, but I just want you to understand it wasn't wild egotism that got us to name this thing after ourselves. It was the force of need. But this did great. We made a pile of money. We thought this was wonderful. Everything was great. Then we made the trabecular metal design, and all kinds of interesting things happened. One is we had a tolerance problem with the humerus because as you make things, as you learn, you can't make anything exactly the same size. You make it a statistical distribution of sizes based on the machining and the molding. And you want to make sure if it's a press fit that the range of sizes that the reamer makes include the range of sizes that seems obvious, right? But evidently they didn't figure that out at Zimmer. And we had a bunch of these that wouldn't go in and wouldn't come out. And we had some wild times, but basically the stem did pretty well. But you learn a lot when you work with industry, because you have to deal with design engineers and production engineers and marketing. Marketing wants to make everything yesterday that anyone ever wanted, whoever whispered in their ear last. The design engineers take forever to design the damn thing. And the production engineers don't want to make anything they can't make perfectly, which is almost nothing. So there's a tension that goes on in all of this. But the trabecular metal glenoid was an attempt to make a metal back glenoid that didn't have the disadvantages of metal backing. That is, it didn't have a stiff piece of metal. It had metal that had the same modulus as bone, because trabecular metal is tantalum that's deposited on a carbon core. So imagine wrapping aluminum foil around a pencil. It looks like a big hunk of metal, but it's a thin shell of metal around a carbon core. And so the thought was this wouldn't stiffen the poly and that they would go. We released this in January of 2003. There was a lot of excitement about it, a lot of pushing, a lot of worldwide interest. We had 96% survivorship and good clinical results, but we had a 5% fracture rate. Was it 5? Yeah, on 5 we did. That's right. We had 15, I think, out of 500. Anyway, they had fractured at the base of the pegs here. And the problem was, we figured out later, is that this is very strong north-south, but not that strong east-west. And these were revised, but we had this removed from the market in August of 2004. So that's, a year and a half, roughly. When we analyzed this, we figured it out, why it was fatigue damage at the base. And don't forget, we're trying to make a metal model, like a metal bone graft, but it could have a fatigue fracture. But what's interesting about this is Zimmer's view is better technique will fix it. The surgeons love it. It's a tiny number, but 15 of them broke, and it was like popcorn, 1. And you wait a little bit, it's 1, 2, 3. And you wait a little bit, it's like 5. I thought they were all going to break. I lay awake at night. I was really worried about it. 500 of them had been implanted. I could just see the whole, it was really upsetting. Louis and I think it was Louis' proudest moment, told the company, take it off the market. Zimmer didn't want to take it off the market at the time. Different people than work there now, if I have any Zimmer guys in the audience. Louis said, I'll get up at the academy and tell everyone you're a bad company, and these products should not be used. He told them that. So they took it off the market. Zimmer told us the system will never recover. And we said, well, what are you talking about? We can't keep putting this in until we understand it. So like academic surgeons, we designed a new one that's a cruciate design that's much stronger. When I wrote this slide, I forget when I did it, thousands have been put in. There was only one fracture from trauma, and it did very well. But guess what? The system never recovered. Zimmer was exactly right. We personally lost millions of dollars in royalties. The company lost its shirt on this product, and this product never caught on again. And the answer is, we do it again. That's sometimes the position you get into with industry, because at the end of the day, you're an advisor. They make the decisions. They're a business. But you have to stand up for what you believe in when you're dealing with it. Now, by the way, this is a 10-year follow-up. They've done extremely well. We have like 15-year follow-up, the ones that stayed in, but no one cares. Do you remember thermal capsulorrhaphy? Right? When thermal capsulorrhaphy came out from Oratech, the North American president or vice president, whatever, was in the locker room wanting to talk to me. I said, how'd you get in here? I'm like in my underwear. He said, well, you won't return my calls. I said, I don't have any IP for you. I didn't design this. They just wanted me to be on an advisory board. That's really an endorsement, right? I said, no one is going to take money to be on an advisory board. Then he showed me the list. The list was like, 3 past presidents of shoulder and elbow surgery, people you would know. I calculated at the time that what they offered me was about $300,000 to do, just to be on this little panel. It's very seductive. Not only that, it was the talk of all the courses. Everyone was talking about this. I was on a televised meeting with the European Society, where a very well-known shoulder surgeon was talking about all the great results he had shrinking athletes. And one case came up where it had failed, shrinking had failed. So he said, what do you do now? He said, I swear to God, shrink it again. Russ Warren turned and said, I don't think I heard you right. What did you say you would do? He said, shrink it again. And he was a big financially involved person in it. The point about this was people really suffered from this. People really suffered. There was chondrolysis, there was early arthritis in young people, there were destroyed capsules. This was an example of a really bad innovation that died out quickly, but it was heavily promoted by our colleagues who were on the payroll of this company. And I've had many false starts. I designed, 25 years ago, 30 years ago, a device to drill through the greater tuberosity instead of using an anchor, because I don't want to use anchors, for a rotator cuff. And a major company made me a prototype, and I met with engineers. And then about halfway through it, I realized, someone's going to bag the axillary nerve doing this. At least the way I had designed it. I didn't like, I wanted to get low enough to get up with a curved. I had a curved passer and everything. So I abandoned it, and the company was not thrilled. But I said, look, if you want to make it, you do what you want, but I don't think this is the right way to go. I worked a lot on percutaneous pinning for fractures, and I was working with Arthrex to develop, and they did develop a system, which is pretty good. And halfway through it, I said, I don't really have the time and focus to keep on this. And then they got really nervous, like I was going to want a piece of the royalties. And I said, no, you make it. If it's good, I'll say it's good. But, I can't stay involved. That was a false start for me. And we've patented a bunch of stuff that never came to anything. From our stems, my NIH stem cell work, we patented a stem cell rejuvenating molecule, because we found out in the research, by the way, everyone talks about stem cells, your stem cells get old like you do. If you look at your stem cells, if you're 70 years old, your stem cells are pretty old too. So your cuff doesn't heal, not just because you aren't old, because your stem cells are old. Moving them around doesn't necessarily change that. And we showed that in rats too, and in mice. So we were trying to look at nuclear cofactors that would fix that. That's not, my co-investigator, my co-PI moved to Einstein. They formed a little company, but I'm not sure that's going anywhere. And there are many, many ideas I wanted Zimmer to pursue that never happened, Dr. Levine. And that continues on. So I think on working with industry, and I apologize if I've been a little rambling, but I've never focused this in a talk, but I actually enjoyed getting this ready. I think you have to there is profit and peril. I think you have to be selective. I think you have to be thoughtful in what you do. You don't want to just react to everyone who comes offering to pay you to do something. I think it's very important to establish your reputation before getting involved with industry. First of all, it'll help you with industry because they want that hit of credibility. But secondly, it'll preserve your ability to walk away if you don't like it, and it'll preserve your standing in your community of your colleagues who respect you. I think you have to follow conflict of interest guidelines really, really closely. Now, I can't tell you, and I followed this very closely myself. There are people who have been accused and investigated for failing to adequately disclose their conflict, when in fact what they did was they used January to December numbers instead of July to July numbers. So they reported, 100 of something instead of 120. Once you're labeled an abuser, it's very hard to recover your reputation. So, when you want to fill out all the forms, you don't want to forget to disclose a conflict. You want to list, at most universities, you have to list all your conflicts annually. But I would advise you, if you do this, and always do what's best for patients. Always think that through in everything you're doing. And if you do that properly, it's okay to enjoy the profits. If they're not ill-gotten, it's okay. And if you're lucky, which is always the best thing to be as a surgeon, better to be lucky than good, it'll go well. And why should your family suffer? The interesting thing about industry involvement is it's the first time my family benefited instead of suffering for my academic career. When I was here at Columbia, Louis and I paid a dean's tax, a department tax, and then we taxed ourselves to run the shoulder service. More than $100,000 a year each for many years, to have extra fellows, to do videos, to do other things, right? We didn't think about it. That's just what we did. We'd go away to meetings and we wouldn't be seeing patients. It was on Eat What You Kill. And I grew up with, my wife knew my colleagues of my age. Dave Alchek was the year after me. Steve O'Brien was the same year. Russ Windsor and I were friends. In fact, at HSS, in fact, we switched. One day I showed up at John Insull's OR and said, "Who are you?" I said, "Oh, we switched. I'm here to do your cases." Okay, it's a different time, right? He showed up in Near's OR. But my wife kept noticing that their lifestyle seemed a lot better than mine. And every time I went to a meeting, she never complained, but every time I went to a meeting, it was less food on the table, right? This was the first time that there was a benefit. So I don't think it's so terrible if you do it properly. I really don't. But I think it's an honest discussion. It's an honest discussion over, what's allowable, what isn't, and how should we manage it. Thank you.
Evan, thank you so much. It's a fantastic talk. And I think the framework you gave was, I think everybody can understand, how to, Michael turned to me on the slide of how you framed the different involvement. And I think that's the first time I've ever seen anybody frame it that way, which I think is fantastic. We have a lot of people here, our faculty, who are very involved with industry. So I think, Mel, you want to talk about your experiences?
Sure. I enjoyed your talk very much, Evan, and obviously loved it when you were here, and have followed your career closely as you wandered across town, and continue to be a Columbia person even wherever you were, in terms of your ethics and your ability to be an innovator. So the issue with institutional either support for innovation or suppression of innovation. What I've seen going around the country is there are institutions that want their faculty very much to be involved in innovation and patent generation, and they want to reward them and to be a partner in that. There are other institutions that say your benefit is being here. The institution that we created for you is your benefit. And what that has caused is a flight from certain institutions to other institutions. And it's not a pecking order. It's not a wannabe.
Yep.
It's Stanford, who has an innovation center where they want people to do it and they reward them and they stay, versus a number of Ivy League institutions which are the opposite of that. I don't say they penalize you, but they denigrate your whatever contributions you make. And you sort of alluded to that a little bit, in what you just said. So I'm not sure what the right answer is, but I think having more partnerships, as opposed to we've created the overhead here for you to think and be free in the old Greek tradition of the academic purity is a problem, because most of the true innovations have come from people that are steeped in the field and actually have some ideas and would like to have a partnership with their institution, and yet they get crumbs in terms of reimbursement for their efforts, which has to be done, in addition to all their other responsibilities. It's not like, oh, that's all you're doing it. So, I mean, how would you advise, now that you're an administrator on the other side?
Ooh, that hurts.
And you're still a student, I know that. But my point is how do you turn that ship to recognize the real contributions of surgeons and basic scientists to the overall good of your discipline and the institution?
Yeah, that's a great question. My roommate at Princeton's father worked for Corning Glass, and he invented styrofoam packaging. And in 1 year, Corning went from like $1.5 billion in broken light bulbs to like $10,000 or something. And he got a letter suitable for framing, of gratitude. Although he did get a new job, he got to be in sales that he'd always wanted. But I think part of that is you got to turn it around and say, what is the institution really doing for you? The way I look at it is, for the institution to say that because you, Mel Rosenwasser, are here, we own what's in your brain, every idea you have from working as a clinician, which you could have in private practice, and saying we put in an infrastructure that supported you. So in my institution at Mount Sinai, to give it some depth, we do have drug discovery programs. We have labs that do small molecule testing, et cetera. We have no way of helping people innovate in surgery. So why should we tell surgeons they can't benefit from that if they're just thinking things up and working only with industry? So I convinced my dean, who, it's an effort to convince him of stuff, that we should build a surgical innovation laboratory. And we're doing that. In a building we just bought, it's like 12 stories, there's a sub-basement that's not clinically usable because it doesn't have direct elevators. And we're building, a large facility for cadaver and animal surgery, for 3D printing, for ideation with companies, links to ORs, links to classrooms. And the reason we're doing it is not just to make it easier to work yourself or with industry or with startups to make something, but right now, if I'm working with a company, I can't convince them to fly my partners or people in another department out to Warsaw, Indiana to hear their ideas, but I can bring them to something at my facility. I can do a case and go down to the lab and try something out, bring industry to us. So it's an idea that we would help people develop things which would justify some share of the profits to go to the institution on some fair method. I'm still making sure it's a fair method and not an unfair method. So I think there are ways we can approach that. Stanford does this a lot, but the other thing is you have to have really good controls, because you can, it's not the end of the world if a Stanford professor benefits from some computer startup, but it does get, as I've given examples, you can go over the line, with clinical. And one of the ways you do that is not just the IRB mechanism, but you have other departments looking over what your department is doing. You can have like a surgery faculty watching what orthopedics is doing. You can have an orthopedist watching what ENT is doing, to have someone removed from the political structure saying this makes sense. And we're trying to do this with the Innovation Lab by having a committee of senior surgeons that would have some ethical jurisdiction beyond just the obvious legal issues, as well as some outside investors or companies. So I think there are creative ways you can tackle it, because you're exactly right. You don't want to choose between the twin pillars of let it be the Wild West, or no one's going to do that here because we're afraid of what'll happen. You have to struggle with it. Like my example of Lincoln versus the hermit in the woods. You want to get something done, you have to tackle the difficulties in life, not hide from them.
Rick talking, it's funny, it comes full circle, because I was a medical student when you were a hotshot young attendant, and I was so enamored by your enthusiasm about all things shoulder. You said something like, I'm going to understand the biomechanics of the IGHL, I'm going to understand everything about the anatomy of the shoulder, do the outcomes research, do the basic.
Youth.
What's interesting is that, full circle, because I look at the primary benefit of industry involvement as that. And the reality is that people who are deeply passionate are horizontally integrated, meaning that you're interested in making care better, improving outcomes, looking at outcomes, understanding the basic science. You know, years later, we call it owning the disease. Like I tell young people,
Right.
you have to own the entire disease, know everything about the teleprompter, run the study group. And actually, that makes you better as a surgeon because you spend time codifying in your mind what to do in certain
Right.
situations, and you talk to smart people, and you evolve, and you've got that work before you operate on patients. And I think that that's the primary opportunity to get involved in industries to make it better, make us better. But I think that those opportunities are diminishing quite a bit. We are now being consolidated, and I think they look at us as surgeons as less valuable to their enterprise. There's less innovation, perhaps, in industry as we sort of move to a different field. So, how would you advise in this real world young people to get involved? Because it's easy to get involved on the bottom of the spectrum where we shouldn't be involved. But I think more and more, less easy to get involved across the spectrum where it may be more important.
Yeah, you know, that's a really good point, Mike. First of all, to your first comment, we used to talk about the triple threat, right? The great surgeon, the great educator, the great researcher. That's been under attack. My own dean has given talks that that's dead. Now you have a department of triple threat. And I go, you know, I don't think so. If you hire a bunch of researchers to do nothing but research and a bunch of clinicians to work in the salt mines and generate money and a bunch of professional educators, you're missing the secret sauce, you know? And I don't think everyone has to be NIH-funded research and national, you know, but if you're not doing it at all, you lose your soul. You know, you lose that core that makes us jump out of bed and come into work. So I think we have to keep cultivating that. And if you can't do it individually, you do it in teams that really work together. But to your second question, I don't know how to answer that. The corporatization in orthopedics, I don't know all the fields. I mean, you know, Bill can tell you, when I started working with Zimmer, I knew 5 Zimmer CEOs. They would take my calls anytime. I could tell them there's a problem, et cetera. They still take my calls, but it's much more bureaucratic. And in some ways, the DPA was like a baseball antitrust exemption for companies, right? They used to have to compete for talent. Now there's a cap on what you can pay. There's a cap on this. There are procedures. They can say, well, I'd love to give you a better deal, but you know, this is what the Department of Justice resolution was. Not that you should be overpaid, but there used to be a little competition and more of a feeling that they had to earn it. And I think they also are being much more responsive to Wall Street and their investors, you know, and private money. So I think that's a problem. I don't have great advice for how to solve that. I've tried to do what I can at the company I work with, but I don't know how totally to solve that, because you have to be working with people you respect and people who share your values to some extent. And some companies are more entrepreneurial, some care more about, you know, the outcomes, and some are just big, you know, monoliths. And I don't have a good answer for you, Mike.
Dr. Lenke.
Yeah, great talk. I've been looking back at my career and my disclosure. I received substantial royalties from Medtronic for the past 20 years. And your talk is spot on, honestly, how I feel about my career. Like you, I decided to become an academician first before I worked in the industry, although from day one, I can tell you I had 4 companies contact me in the first week of my practice back in 1992 to become a consultant. I didn't start looking at the industry until 2000 after I was a 10-year full professor.
Okay.
Hopefully I have established my career by then. Another point you just made that I wasn't going to say anything, but I think it's so true, is, you know, the people do matter.
Right.
The leaders of these companies. So basically, 2000, I had a decision to make for company A or company B. I personally not only took myself but my wife with me on 2 day trips. We spent all the company executives.
You're a smart man.
Decide who I'm going to partner with. And honestly, after that trip, my wife and I made the decision it was going to be Medtronic because of the people, the way they present themselves. Obviously, you know, they're a for-profit company. There's no hiding that. We felt much more comfortable with their motives and personalities and basically our motives better. So that's what we decided to partner.
You know, many of us, you know, your partner, your husband or wife is your major advisor. And it sounds silly, but it's actually very helpful to talk things out at home away from the structure of all this. Our chairman of our board of trustees, Peter May, is a wonderful guy, and Lenny's his wife. We had a CEO that only lasted a very short time that they recruited. And he tells me the story of they did the search for the CEO, and not all the committee meeting members were at every search committee. And in the end, they picked someone, and I remember he seemed a very uninspiring guy when I heard him talk. So they went to the dinner to welcome him, and Lenny's the first time she met him. And as they're walking home from the meeting, Lenny turned to Peter and said, "That's your new CEO? Good luck." And Peter lay awake at night because he'd never known Lenny to be wrong about a person, and they'd been together so many years. And sure enough, Peter wound up firing this guy within, 2 years. So I do think whoever your trusted advisor is, in your case, you talk to your wife. Some people have a partner, a junior partner, or a colleague who they aren't even working with industry, but they want to get an outside look. Some people use college friends. There is some value to bringing in some trusted advisor, independent of everything, and talking it through. And sometimes you begin to understand it a little better. The problem, though, Larry, is CEOs change. I've been through, as I said, 5 CEOs in my career with Zimmer and mergers and things like that. And sometimes the people you started with that you thought really shared all your values, you wind up with people that, and it's hard to change. I tell stories of when I walked away from something, but it's hard to walk away from something you've spent 3 years designing. And the other part about conflict of interest is when people say, I have a conflict, it's almost like a child, right? I mean, you designed it, everything about it is the way you thought it should be. Your research, we did research here in the labs here on articular geometry and tribology. So when you've designed something based on all your research that's just what you think it ought to be, even if they don't pay you, you're going to want to use it. You're going to want to tell people. That's intellectual conflict, right? So it can be a tough thing.
But the point also, like 21 years now, I've not had one patient decline to use me as their surgeon because of my conflict that's disclosed during every patient, every form is signed.
Yep.
St. Louis and here, not one patient has refused to sign that form.
One of the things for the residents that's really important, especially if you're considering an academic career, is to understand that each academic institution has different policies on what your role, if you are an innovator, who owns that intellectual property, and what the ratio is. There are some places where it's 50-50. There's some places where it's 75-25 in favor of the institution. There are places where they'll say, if you're doing innovation, but it's not on Columbia's campus, and it's not using Columbia resources, we have nothing to do with it. And that's not true at every place. Other places will say, we don't care where you're doing it. You're a WashU faculty member, it doesn't matter. So those are conversations we don't really talk about so much, but really important if you're interested to understand that. And universities are risk averse. So when you look at the language, so we've been working on a scaffold that many of you know about for many years, and we're just getting the licensing descriptions done and definitions. And Columbia is taking an extremely risk-averse position that's putting some of the risk on the inventors of the technology.
By the way, never do that.
Well, every university does it, though.
I know. Product liability, though. I got to tell you, you don't want product liability.
Yeah, it's
I was indemnified to the last dollar of Bristol Myers Squibb for, that's a limitless wealth.
So it's
They'll take your house, your bicycle.
and then when you look at Evan and our story with Zimmer, we have had 3 CEOs, we've had 4 project managers, we've had 1 original surgeon member die. We had Zimmer purchase Biomet without understanding that Biomet was under federal investigation, which shut down everything for 2.5 years. And so before you know it, it's been, since 2012 to 2021.
But who's counting?
But we're finally, our practice is finally coming out in January.
Just one other point, I've been comment on this, that for the residents, that didn't happen to me, but I have some peers where their name was, in other words, you start working with a company, they put your name on something, and then that relationship ends, but they own your name, and now your name is coming out with a product that you have nothing to do with, that you don't even agree with, and you're trapped with your name being out there for that.
Yeah, so with the Biliani Flatow, we had to give him the name because otherwise the whole thing would have gone down. So I was at one time my name was a registered trademark of Bristol Myers Squibb, which owned Zimmer at the time. And in fact, they have to pay me a name license if the royalties, there's a whole complex thing. But usually what you do is you negotiate how you will be represented. And most universities will allow you to be Bill Levine. This was designed with a team that included Bill Levine, professor of orthopedic surgery, Columbia University, and that's it. You can't say that Columbia endorsed it. You can't do it. So you negotiate it, and you have to put it in the agreement. And many agreements allow you to revoke your name if you take away your name if you leave before design freeze, for example, so that they can't design a new thing and put it under your name. But like anything else, you get wise and then you get old and retire. You learn all these lessons the hard way. And anyone who wants to email me, if you have a question, feel free to email me. You learn all these little tricks. You have your name, product liability, that's a big one, design liability versus manufacturing liability. You learn about tolerances, you learn about clinical trials, pre-market approval. Is this going to be a 5? It's all. I could talk for days and days and days about what I learned in this. And it's harder in drugs, actually, because drugs, by the time you do all the studies, your patents almost run out. That's why they play this game of small changes and patenting it and having trade secrets. At least with devices, at least 510K devices, you can come out within a few years. But it's your name is in medicine, we don't own factories, we don't have capital. Our name and our reputation is all we have. You don't want to trade that lightly. You
touched on it, Evan, the AdvaMed. You didn't actually say the word. It started out as a guideline and became fiat.
Right.
And now is, the reason that they can hold down.
It's Chris Christie, man. It's Chris Christie.
And control the surgeon market entirely.
I can't wait for someone to sue Mount Sinai and say we overpay our surgeons so I can say, I'm sorry. I would like to pay you more, but I'm under court-ordered agreement not to pay you that much. I'm thinking of trying to instigate a suit, get some old friend from college to do it. That's what they have.
They truly are guidelines. Have you ever read them, which I have?
Yeah, AdvaMed is a good website.
And the thing is, it's each company interprets it in terms of their risk management of how they want to deal with it. It's not actually stipulated.
Yeah, but AdvaMed, Mel.
A pen versus a CD.
Yeah, but AdvaMed, to be fair, AdvaMed is an industry association, a voluntary association. So what you see on the AdvaMed website, which is a good reading, is really what the companies got together and agreed to, hoping no one would come after them, right? And then Christie went after them. And as a result, they had court-mandated monitors who set up a program of compliance. And I don't know how many of you deal with compliance. Anyone here know your compliance people here at Columbia? Your compliance people are not out, to see you, collect more than you ever did and to see your billings and collections go up. They're there to make sure you don't bill for a level 3 when you forgot to ask about toenail fungus, in your H&P, right? And take that same mindset, those compliance people, and now vest it in a corporate office at a company. And you say to the corporate office, I would like to pay Mel Rosenwasser for his work on this nail. They do things like show me the minutes where he was at the meetings. Do you have records of the good ideas he had? Do you have an email showing that he actually told you something of value? Well, if you can't do that, you can't pay him royalties. But he's been working for 4 years for us and coming to meetings, and we have a product to sell. That doesn't matter. Compliance, you have to show all that. That goes on. And that's what happens. It becomes a self-regulating. And then there's this subtle interest they have, because the compliance doesn't say if we don't pay Mel, we're going to give it to charity. They say if we don't pay Mel, it goes into our budget, which is not doing so well this year because of COVID, right? So, it's not like these compliance guys are going to get, disciplined for not being so fair. Forgive me if I sound a little cynical, but I've looked into the belly of the beast, and these are all good people. I don't want to demonize people. The people working in companies are honest, church-going, good wives and husbands and fathers and mothers. And if you met them at a tennis court, you'd think they're nice people. The people in the university are good. The dean's office are good people. These are not bad people. It's not like a morality play. It's just that when you look at the institutional milieu and how it grows up. My wife worked at Citibank at one point, and the marketing people wanted to give a credit card to every man, woman, child, and dog in America because they got bonuses based on market share. The credit people didn't want to give anyone a credit card because they got bonuses based on default rates. And the legal people were happy to give a credit card to anyone who would be videotaped signing a 300-page affidavit and producing their passport, because they had different institutional incentives. Much of my job is figuring out in my own institution what everyone's incentives are so I can head them off at the pass when I want to get something done. That's just life, you know, that's just life.
Well, thank you very much for coming up.